welcome, and I'm going to start the recording. I think I already started the recording, so please go ahead, Dr. Azza. Thank you.
Hello, everyone. Thank you for being here and for participating to this event. Thank you, Hayat, for organizing this event. I really appreciate your enthusiasm and your requirement to do such an event for all people to get a benefit from it. Yeah, as Hayat said, I'm Dr. Azza Attia. I'm Egyptian as origin, and I've been doing my fellowship and all my specialty. I'm a physician in origin, and I did all my specialty in France, where I've been working also after my fellowship as a consultant of clinical genetics. And then I moved to Egypt, where I've been working for 14 years in Egypt, and then I moved in UAE. So I've been specialized in every subspecialties in genetics, including oncogenetics, which is cancer genetics, pediatric genetics, congenital anomalies, and different kind of genetic anomalies which are related or genetic problems or problems of health which are related to genetic origin. So I've seen a lot of patients with family history of breast cancer, and I've been screening them. And I'm actually working in a lab in UAE, which is offering also breast cancer panels. And of course, we are trying to raise the awareness of people about breast cancer. And since this month was the Breast Cancer Awareness Month, so we decided to do in the last few days this event to help people to understand a bit more about it. So that's about me. If you don't have any question, let's start the presentation, or would you like to wait a little bit for more participants, Hayat? It's up to you.
No, we start because it's recording and it's first thing in the morning, so people will be working. And I promised them a recording.
Okay, that's good. So I'll be sharing my screen. I don't know from where shall I share it. Record, share screen. Okay. Can you see my screen now?
Yes, we can.
Okay. So I'll be presenting just a minute. No way, take time. So as we said, we are going to talk about breast cancer awareness. So these are the different points that I'm going to discuss during the meeting. So first of all, an introduction about our genetic material to make it easy to understand what I'm saying later on. The types of the genetic tests that we can have, the types of breast cancer, because there are several types, fact about breast cancer, which are important to know, and breast cancer risk factors as well. What is the importance of early diagnosis of breast cancer, and what are the genetic causes of breast cancer? Why, when, and who should do this genetic test, and what are the clinical management according to the genetic profile of each person. It's different. And what are the general and specific measures to be taken when for breast cancer or to decrease the risk of breast cancer. Please, if you have any question, of course, you can stop me to ask, or you can keep this question to the end of the lecture. It's up to Hayat to decide. I don't know why it's not going. Okay, from here. So this is just an introduction. What is the genetic material in our body? So in each of our cells, we have what we call chromosomes. These chromosomes are stick-like structures which are present in the nucleus. They are highly compacted form of DNA, which is carrying our genetic information. And why it is so compacted? To protect it. So if it is not so compacted, it will not be protected, and anything can cause a mutation in our genes. That's why it is so compacted in the form of chromosomes. So we have, each of us has 46 chromosomes in each cell, except for the gonad cells, which contains 23 only chromosomes, not 46. And these chromosomes are exactly like books. They contain our genetic information, and we have 46 books. We receive 23 books from the mother and 23 books from the father to make a 46 books by the end, okay? Inside these books, we have pages, and these pages contain letters and sentence which make different chapters. These different chapters are our gene. We have about 20,000 genes. And so for each gene, there are several letters and sentence representing these genes, okay, which are copied or carried inside these chromosomes. So these genes are in form of few letters, only 4 letters represent our gene, and the distribution of this letter will make one gene different from the other. Each gene is a fragment of DNA, which is informing or giving information to a certain protein to function, and it will be causing our the protein production, and this is expressed inside the cells as a functional protein. So as you see here, the chromosomes are the books. When we open these books, we will find sentence, which are the genes. If the genes are good, well and good, it will be coding for the needed protein, and the protein will perform the function required by the cell. If there is any problem in this protein will not, or in the gene, the protein which will be produced will not be functional, and in such case, or it will be, might be hyperfunction. So it is loss of function or increased function, which we call gain of function. And in both cases, it is a problem, or it can produce a genetic disease, okay? So these are how our genetic material is organized. So what about genetic diseases? Genetic diseases are of 2 kinds, whether monogenic, what we call inherited diseases, or multifactorial disease. I'll just explain what is the difference between both, because it is important to know. So when we have one gene anomaly causing one disease, regardless of other factors, this is called monogenic disease. And as I mentioned before, we have about 20,000 genes of these monogenic genes, okay, of these genes, okay? So if we have one anomaly in these genes, not all the anomalies, but specific anomalies which affect the protein production. If we have this anomaly, this will cause a disease. So the other kind of genetic predisposition, what we call genetic predisposition diseases, they are not only relying on genetic factors, but they will rely also on environmental factors and lifestyle factors. So the 3 factors are very important in development of the disease, okay, or of a problem, like for example, diabetes, type 2 diabetes, which is the adult diabetes. This is a genetic predisposition. The person who will develop diabetes type 2, it has a genetic predisposition factor. And then he lived in an environment which enhanced this factor, because he has been exposed to whatever chemicals or problems which enhanced the genetic factor to appear. And then he had a lifestyle which also enhanced the appearance of genetic factor. He is eating, for example, a lot of carbohydrates. He's not eating vegetables. He is not drinking enough water, whatever. So these are multifactorial diseases. Okay, this is an important difference to make, or to understand the types of genetic diseases. So then came to the type of genetic test. According to what I've said in the previous 2 slides, so whether we do chromosomal analysis, and in such case, it is called a karyotype, and in such case, we will see the books, but we will not see the letters inside the books and the sentence and the chapters. So it will only be examination of the book from outside. If we want to go or to dig deep and to go and to do the genetic analysis, we need to open the book and to read these sentences which are present in each chapter. So we can read all the chapters, or we can read only the chapter of interest or the sentence of interest that we are interested in. So this is a specific gene analysis. Panel analysis means that we have several genes which can be involved in the same disease, and we are analyzing all of these genes to kind of save time and energy, because instead of doing one gene after the other, we are doing the whole panel together. So this is called genetic analysis, okay? So it is called molecular analysis or panel analysis or gene analysis, while the other is called chromosome analysis. What we are doing in breast cancer is mainly gene analysis. In very few cases, we are doing chromosomal analysis. It depends on the case itself, but in most of the case, it is a gene analysis, and mainly it is a panel instead of specific genes to save time and money. So I'll just explain a bit more about the inheritance of cancer, because as I explained before, we have the monogenic diseases and we have the multifactorial diseases, as I explained. In cancer, it's a little bit different. It's also monogenic, which means one gene can cause cancer, but it's not only sufficient to cause cancer. It has this, if this gene is inherited as a cancer gene, I will be susceptible to develop cancer, but a second hit theory or a second hit event should happen for me to develop cancer. It's not enough only the inherited mutation to cause cancer. So that's why in some families, we have persons who are carrier of the genetic condition, but who will never develop cancer. This is for two reasons. Whether their body didn't express a second mutation, which caused the development of cancer, or or the penetrance, what we call penetrance, which means the expression of the gene is a little bit low in their case. And that's why he didn't express himself. The mutation didn't express itself. So this is for inheritance of cancer, which is a little bit different. I will explain it more in the few next slide. So I'll talk now about breast cancer. I will focus on it. So what are the types of breast cancers? We have two kinds of breast cancer. We have the sporadic one and the inherited one. There is a big difference between both, and most of the people confuse both together. However, it's important to differentiate between them. So in the sporadic cancer, it accounts for about 90 to 95% of cases. So most of the cases are sporadic, they are not inherited, while the inherited one are 5 to 10% of cases only. The sporadic one, as it said, it occurs sporadically, which means then we have one person in the family who has it only, and it's not really systematic in the family. While for the inherited one, it runs in family. You will find that the mother has, the daughter has, the sister has the cancer, whether breast cancer or other types of cancer. Even I will explain this later. So in the first one, usually there is no family history of breast cancer or other types of cancer. And even if there is if a history, it will be one of the relative which is far away and it's not really related to the patient's second or third or fourth degree relative. And it's only sporadic. It's not very systematic in the family, or it doesn't happen in each generation. While in inherited cases, it's usually there is a positive family history, whether of breast, ovarian, colon, prostate, and pancreatic cancer. And we'll see later why all of these forms of cancers are related together, because the causative gene is more or less the same. So it's not only about breast cancer. Ovarian cancer is very important. Family history of ovarian cancer, it's much more important than breast cancer, but because it is less prevalent, that's why we are not talking about it too much. But it is very important because this means that this gives us an alert that there might be something in the family inherited. Colon, prostate, and pancreatic cancer also can be caused by the same gene which causes breast cancer. Of course, if we have a family history of a male with the breast cancer, this is a very highly, because also males can have breast cancer, this is a highly indicative that there is a genetic factor or inherited factor behind this cancer. The absolute risk for sporadic cancer is about 1/8. Absolute risk is a likelihood development of breast cancer for a person over 80 years of lifespan. This is 1/8, which is 12%. So among 100 patients or among 100 persons, only 12 will develop and develop breast cancer, okay, which is 1/8. The risk factor or the risk of development will depend on mainly on genetic profile, environmental factor, and lifestyle, as I said before, because this is a kind of multifactorial condition. While in such case, risk of inheritance is very high, not only 1/8, it is 50%. It might develop at younger age, even below 40 years old. And the risk of development can be up to 80% risk of development because the person inherited already one of the copy which are carrier of the genetic mutation. So her likelihood development of a secondary mutation is high, especially if she is subjected to a lifestyle which enhances this kind of development of secondary mutation. And then the development of cancer is up to 80%. This is for the two types of cancer. So then we will see what is also the difference between both regarding the risk factors and what is the science behind it. So for sporadic breast cancer, the age usually is above 50 years old. So all female are liable for a breast cancer because it's the most common cancer all over the world in females. So the age here is above 50. What are the factors which enhance the development of such kind of sporadic breast cancer? Early menstruation and late menopause, because in such case, the patient is, or the patient, yeah, is exposed to high level of estrogen and progesterone, which are the sex hormones. And these sex hormones, we know that they are increasing a little bit the risk for breast cancer. The timing of pregnancy is important because patients who developed or females who have early pregnancy will be protected by the hormones of pregnancy against breast cancer. While those who have never been pregnant or have been pregnant after the age of 35 years old, they are more prone for breast cancer development than their fellow who have children before this age. Also, hormonal replacement therapy, the same, because in hormonal replacement therapy, you are taking estrogen, which is highly enhancing this kind of cancer. Oral contraceptive pills, which are mainly formed of estrogen. So these hormones favor the development of cancer. Some races and ethnicities are liable for cancer, breast cancer more than others. And the lifestyle factors, which are very important factors, are obesity, lack of physical exercise, this predisposed to cancer, all kinds of cancer, not only breast cancer, alcohol and fatty food, and also exposure to radiation. These are the risk factors that we have to avoid during our life to avoid the development of sporadic breast cancer, okay? For inherited breast cancer, the history is different because we have a family history of breast cancer, especially at young age. The patient will tell you that my niece or my aunt or my mother developed cancer before the age of 45 years. And there might be also a family history of other types of cancer, as I mentioned, ovarian, pancreatic, prostatic, gastric cancer. There might be a history of male relative with breast cancer, which, as I mentioned before, highly indicative that it might be a cause caused by inherited breast cancer. Female relative with bilateral breast cancer, when the breast cancer come early and come aggressive and come in both breasts, this means that there might be a genetic factor behind. That's why he is so aggressive, or it is so aggressive. And the patient herself can have a previous personal history of breast cancer or other kind of cancer which developed early in her life, especially patients with Hodgkin lymphoma, because these patients usually develop Hodgkin lymphoma in early ages. And then they are exposed to high dose of radiation, and this high dose of radiation predisposed to inherited to breast cancer. But in such case, it can be inherited also or acquired because of the irradiation. So it is we have to dig deep and to see what is the cause exactly. So this is just an explanation how the age play an important role. So if you see here, by the age of 25, the risk of any female to develop breast cancer is one. Of course, this risk is different from one ethnicity to the other, but it is a general risk. At 25 years old, it is 1/19,608. And while at the age of, at elder age, it will be, for example, at the age of, let's see, at the age of 60, it will be 1/24. So you see how many times this risk has been multiplied in just a few years, okay? And the overall risk, as I mentioned before, is 1/8. This also diagram, it shows that there is a difference in the breast cancer development according to the ethnicity. So this is breast cancer incidence in US, in women by race and ethnicity. So a white woman will develop, has higher risk for development of breast cancer, while Black women have a lower risk. However, the Black ones, I'm sorry to say white and Black, but it is what is mentioned here. Dark colored skin usually develop breast cancer are more aggressive in their case than in the white one. So the white people have more incidence to develop breast cancer, but the dark colored skin has lower incidence, but once the cancer is developed in their case, it is more aggressive than in white people, okay, and so on. So what is the 5-year survival rate of breast cancer? If we are exposed to breast cancer, or if we have a certain risk for breast cancer, which we all have, because at least we have the sporadic risk of breast cancer, which is 1/8, as I mentioned. So why is it important to test for it? Someone can say, if I have this risk and I'll develop it, let me develop it, and that's it. Why shall I predict if I'm at risk or not? No, it's very important because it will change the management. And you will see here that the 5-year survival rate is different according to the stage of development, or the stage of discovery of the breast cancer. So if you are at stage 0, which means in situ means that it is only a tumor localized in few cells, and it didn't exceed these few cells inside the lobules of the breast. So if you have it at stage 0, this means that it is confined within the breast and it is very small. And in such case, the 5-year, if we discover the breast cancer at this stage, this means that you will be treated correctly, and the 5-year survival rate will be 100%. While if we wait till stage 1 and 2, when the breast cancer start to grow a little bit, it's still confined within the breast, but it reaches 2 to 5 centimeters. In such case, the 5-year survival rate will be 98%. So if we wait a little bit more and we reach the stage where it spread to lymph node, this means that it goes outside the breast, and still its size is small, but it went outside the breast. This means that the survival rate will decrease in 5 years, will decrease to 83.6. And so on in stage 3, where it will spread to locally and spread to lymph node, and the size will be more than 5 centimeters or equal to it. In such case, the survival rate 57%, and in stage 4 is a metastatic stage, the 5-year survival rate is 23.4. So as we see, a big difference between the discovery of the breast cancer 5-year survival rate in stage 0, where it is 100% 5-year survival rate, and stage 4, wherein it is 23.4% survival rate, which is less than 1/4 of the survival rate. So what is behind the breast cancer genetics? So we have 3 kinds of breast cancer. I explained before the sporadic one and the inherited one. These 2, I explained them before. But we have also a kind of breast cancer in which you have a certain family history, but when you do the genetic test for the patient, you will not find that she is carrier of any mutation, but still you don't know if it is really those mutations that you have been searching for which have been causing the cancer or not, because we don't know everything about genetics. We are still discovering every day a lot of information that we ignore, or that we don't know, sorry, that we are ignorant for. And the second point that, so maybe the mutation wasn't detected in our case, or maybe there is some kind of genetic liability in this family, which makes that they are more liable for breast cancer than others. So these are the 3 different conditions. So the sporadics that I explained in the beginning, the inherited one, which represent 10%, 5 to 10%, as I mentioned before. And there is a group which is called the familial breast cancer, in which we don't find a mutation, but still there is a positive family history. So we have to dig deep and to give a certain protection to those patients is more than those of sporadic breast cancer. So these apply to all kinds of cancer, not only for breast cancer. So we have the inherited form, we have the familial form, and we have the sporadic form. This is for all kinds of cancer. So what are the genes which are involved in breast cancer? We group this gene in a panel which is called HBOC panel. What is HBOC? It's hereditary breast ovarian cancer panel. As I mentioned before, the genes which cause breast cancer can cause also ovarian cancer. That's why some patients who have breast cancer, we have to follow up them really closely for the ovaries because they might develop also ovarian cancer. So as I mentioned before, the breast cancer cases with unknown genetic origin can extend up to 90%, but we have 5 to 10% of patients in which we will find some mutations. So the most common and well-known genes are BRCA1 and BRCA2, which are very famous genes and detected for all families which have a family history of breast cancers in all patients with this family history. But we also have a certain panel of other genes which might be involved in this condition. So if we do, for example, BRCA1 and we don't find the mutations, this doesn't mean that the patient doesn't have a mutation. We have to go for BRCA2 and then detect it. If she doesn't have a mutation, we have to go to other gene to test them. So instead of testing one gene after the other, what we are doing, we are taking the blood sample from the patient, testing her for all the genes together, and then telling her if we find a mutation or not, okay? Which will be time saving and money saving also, because doing individual tests is more costly than doing each test alone. Individual test is more costly than doing the panel together, sorry. So this is the two-hit theory that I explained before. So the patient usually inherit a certain mutation from the family, and then a second event arrived and hit the second copy of the gene, and that's why the two copies are non-functional, and that's why the patient has this risk of development of breast or develop breast cancer. So what shall we do in front of this kind of condition? So first of all, we have to take the family history from the patient. Family history of breast or ovarian cancers, this is considered as a red flag. We cannot just ignore this history. The patient has to talk with her physician about this history of breast cancer. I know that in a lot of family, it is a taboo subject. We cannot talk about this subject, but it will not help. At least you have to be relieved psychologically by talking about it and be reassured by your doctor. Even if it is a sporadic breast cancer, he will reassure you according to the history that you will be given. But not talking about it, I don't think that's the right decision. You should talk about it. So there is a family history of breast or ovarian cancer. So here a red flag is raised. And then you have to talk whether to a genetic consultant or to your general physician, who will direct you to genetic consultant, or if he knows how to do the test, he will ask for the test HBOC panel that we talked about before, to do it and to analyze the different genes which are involved in breast cancer. We have two situations: or we have a negative result or we have a positive result. In case of negative result, if there is no really a very strong family history and some patients are doing this genetic test only for screening. They don't have a positive family history, but they would like to do it. So in such case, the risk of breast cancer remain as that of general population, which is about 8 to 12%. And the risk of ovarian cancer is 1% approximately. This is the general risk of any woman in the population, even if she doesn't have any genetic predisposition or genetic risk. And in such case, this patient or this woman will do a mammography and clinical examination every year, starting from the age of 40, okay, for all women. If we have a negative result, but still we have familial risk, and we know that several persons in the family of this patient, or the other criteria that I mentioned before, which is a young age cancer or bilateral cancer, or those cancers which are really indicative that there might be something inherited behind, in such case, the risk of this patient to develop breast cancer is up to 40%, and her risk for ovarian cancer is up to 11%, even if we didn't find the mutation. And in such case, we have to do mammography or mammogram and MRI every 6 months. So once mammogram and the other time mammography. So over a period of a year, each 6 months, the patient will be covered by one of these investigations. Once mammography and the other time is MRI. And then clinical examination every 6 months by her doctor or her gynecologist. If the result is positive, in such case, the patient has a hereditary risk and she has 80% risk of development of breast cancer and more than 40% risk of development of ovarian cancer, as I mentioned, because the same gene can cause breast cancer or ovarian cancer. And we don't know why in some families or even in the same family, sometimes it is expressed in the breast and sometimes it is expressed in the ovary. We have different expression inside the same family even. And in such case, if she has a positive family history and positive genetic test, we will do mammogram, we will do MRI every 6 months, one of them, clinical examination every 6 months as well. Prophylactic surgery can be done as well, and sometimes prophylactic treatment. So as we see, we have two kinds of measures. We have general measures, which are like talking to your doctor, lifestyle choices. You have to choose your lifestyle and to avoid anything which predispose to cancer. Mammography or mammogram every starting from the age of 40, clinical examination starting from the age of 40, MRI and biopsy in case of any doubt about any lesion in the breast or any breast density, and genetic screening, which can be done as a prophylactic measure or general measure, or it can be also done as a specific measures. When we have a positive family history, it will be screening and diagnostic test as well. And of course, avoid risk factors. In both cases, more frequent examination and investigation. These are one of the specific measures, prophylactic surgery and prophylactic treatment. So as we see, the genetic test is important. It is considered as a cancer biomarker, not only for prognosis, which means that I'm checking if the patient has this risk or not, but it is also diagnostic. It is diagnostic because it will diagnose if the patient has a mutation or not. And according to the type of mutation, we can give the treatment. Nowadays, there is what we call target molecule or target therapy. Target therapy means that we know what is the mutation, and then we are targeting this mutation by giving a specific treatment for this mutation. This happened for BRCA cases. We are giving them anti-BRCA treatment. This happened for HER2-neu cases, patients who have HER2-neu expression. We are giving them anti-HER2-neu treatment. So we can, in such case, we can give a specific treatment instead of giving chemotherapy and radiotherapy, which kills the normal cell as well as the cancer cells and give a really bad side effect with not prognosis of it is not very good. And it will be predictive as well to predict which treatment, as I said, is important for me, the pharmacology, which treatment is more suitable for my case. Recurrence, it will predict if there will be recurrence or not. And it will be important also for monitoring, because in breast cancer, we have sometimes a kind of remission with time, and we have to monitor the patient. So we have to do regular tests for the patient, not for the blood test, but we can do also what we call, it will be blood test also. It is kind of blood test, which is checking for circulating genetic aberrations in the blood, coming from tumor cells circulating in the blood. It is called liquid biopsy. I don't know if you already heard about these terms before. So we are taking from a simple blood sample of the patient. We can detect if the patient have a recurrence of the cancer locally before even the lesion appear in place, because these tumor cells send some of its DNA in the blood, and by analyzing the blood, we'll be able to check if the mutation is present in the blood or not, in the plasma of the patient. So these are, and of course, we'll mention Angelina, who did a prophylactic mastectomy and also prophylactic ovarectomy. I think she removed also the ovaries because she was carrier of BRCA mutation. and she developed a small lesion. So she checked, her mother died from breast cancer, and I think her aunt also died from breast cancer. So she decided to remove both breasts as a prophylactic treatment and both ovaries. Thank you very much. And if you have any